Thanks everyone joining today for this very interesting webinar. Today we're going to debate a very sensible topic about left main PCI management in terms of PCI versus CABG. In my opinion, after the publication of Excel trial, 3 years and then later on the 5 years results, brought a lot of controversy, a lot of probably unnecessary roughness in between our cardiovascular community, between surgeon, interventional cardiologists, and cardiologists, and so on. So I think what we should do now is probably try to put the things back together and move forward for the sake of our community and as well for the patients as well. So that's why we're here today. So first of all, say thanks to the Latin American Society of Interventional Cardiology, who is the sponsor or the organizer of this event. And then, of course, say thanks to the speakers today. We are 3 speakers joining this conversation. Let me just put let's stop share again, sorry. So first we have Dr. Richard Whitlock. He's a professor of cardiac surgery at McMaster University in Hamilton, Ontario, Canada. He's a true cardiac surgeon trialist. He has run a lot of large clinical trials. If I understand properly, in the last 2 largest trials of Richard, he randomized more than 10,000 people with cardiac surgery to different interventions, and of course, many thousands to come. And so it's an honor to have Dr. Whitlock with us today. And it's also an honor to have Dr. David Cohen. He's a clinical trialist, interventional cardiologist, and professor of medicine in Kansas City, Missouri, in the United States. And on top of his vast experience on clinical research and clinical trials, he had made major contributions in terms of quality of life and cost effectiveness analysis of several interventions we use every day in terms of coronary disease and structural disease. So it's an honor to have both speakers. And my name is Pablo Lamelas. I'm an interventional cardiologist at the Cardiovascular Institute of Buenos Aires here in Argentina. And I also have an appointment as an assistant professor at the Department of Health Research Methods, Evidence and Impact at McMaster University in Canada as well. Okay, so we are ready to get started. These are the slides. So as you can see, the names are not in order. There's kind of in a random fashion in the screen because we couldn't get consensus who goes first. I mean, nobody wanted to go first in the list. So if we cannot get consensus on this, you can imagine that we cannot get consensus on more important stuff. So let's try, I think, good start though. So 3 housekeeping things to say. First of all, we are being recorded. That's right, Juan. We are recording that right now. Then this will be available on SOLACI.org channel on YouTube. So you can view again or review or share. And then we're going to answer questions at the end of the session, probably in the last 20 or 30 minutes. So please use the Q&A section to put your questions. So avoid the chat section for this purpose. And then we're going to do our best to answer them. And then finally, there is a translation to Spanish live at the moment. So if you go on the bottom of the screen, there is the world icon. You just click there and you will select Spanish and there you are set to go. Okay, so I will give the opportunity to talk to David. He will be moderating the session and then Dr. Whitlock will make the first point. Okay, so thank you, David and Richard for joining today.
Thank you for having us.
Yes, thanks very much, Pablo. So I'll be just leading off, setting the stage with the Excel trial. Hopefully most people are aware of this and have logged on because you're confused or have questions. So Excel was one of 4 major randomized clinical trials in the last decade or so to look specifically at revascularization for patients with left main coronary disease. About 2,900 patients were enrolled, but 1,000 of them went into the registry, patients who were either unwilling to randomize or were felt to have only one option. We're going to be focusing the discussion today on the randomized cohort, which ended up being a total of 1,905 patients who were randomized 1-to-1 to either coronary bypass surgery or to PCI with the Xience cobalt chromium everolimus-eluting stent, which is one of the current favored drug-eluting stents. Next. These are the outcomes that were presented at 5 years. These are not the primary outcomes. The primary outcome was at 3 years, but this is the data that were most recently presented and the most complete data with 5-year follow-up on all of the participants. One can see here death from any cause, which favored bypass surgery with an absolute risk difference of about 3%. And if one looks at it in terms of an odds ratio, about a 38% increased risk with PCI. Stroke, on the other hand, favored PCI, although was not statistically different. Early benefit emerged and then stayed relatively similar throughout 5 years of follow-up. Myocardial infarction, probably the most controversial endpoint for a variety of reasons, and we'll get into this in some detail because the curves crossed. So there was an early, using the protocol definition of myocardial infarction, there was an early excess with bypass surgery, and then you can see that the bypass surgery curve stayed relatively flat and the PCI curve continued to increase. They crossed a little after 3 years. Over the entire time period using this definition, there was no overall significant difference. And then ischemia-driven revascularization obviously favored bypass surgery with about a 7% absolute difference, about a 84% relative difference. This was not part of the original primary endpoint, however. And we'll talk a little bit more in detail about this later as to why it really doesn't belong with the other three. Next. In terms of other outcomes and composite outcomes, it's again important to recognize that because the curves crossed to some degree, these analyses were done in a variety of different ways. It's again it's easiest just to look at the overall event rates, and we'll be discussing those throughout. So the primary outcome in this 5-year analysis was the same as in the 3-year analysis: death, stroke, or myocardial infarction. There was no statistically significant difference in terms of an odds ratio, although there was a numeric excess in the PCI group. If one looks then at the kind of most important endpoint, which is death from any cause, one can see that this favored bypass surgery, as I showed you already, an absolute risk difference of 3%, relative risk difference of 38%. But if you look into the causes of the mortality, definite cardiovascular mortality did not really differ significantly. There were excesses in non-cardiovascular and in undetermined causes of mortality, which led to most of the risk difference. And we will be discussing mortality and different ways of interpreting this. Myocardial infarction, as I already showed you, ended up being fairly neutral, but the patterns differed. Peri-procedural myocardial infarction, according to the trial definition, was higher with bypass surgery. Non-procedure related spontaneous myocardial infarction during follow-up flipped and favored bypass surgery with a higher rate in PCI. And those are really the main clinical outcomes. I don't know that there's any more on the clinical outcomes we're supposed to cover. So we'll switch over and let Rich take on the first question spanning from these data.
Great, thank you, David, and thanks again, Pablo, and thank you for arranging this. Hopefully we have a constructive discussion. So the first point, and when I first read Excel, the trial, I truly didn't read it as a surgeon. I read it as a methodologist. And I looked at the primary outcome, the non-inferiority design, and the timing of the primary outcome. And I really asked the question, was this the right target? And I'll tell you why I asked that question. So the investigators chose to use a non-inferiority design. You choose that design when you have an established standard therapy for a condition, and you have now come up with an alternative that may offer additional benefits to patients, and that benefit may be shorter length of stay, greater convenience. But an important thing is that you have to establish that the alternative therapy maintains the benefits of the standard therapy. So in this case, PCI was being tested against a standard, which was CABG for left main disease. CABG was established as a standard for left main disease over medical therapy in 1994 after the publication of Yusuf et al., where they did a meta-analysis of 7 randomized trials. And in that, they demonstrated that there was a substantial benefit, in fact, a 68% reduction in the risk of death of CABG over medical therapy at 5 years. And I'll show that again in the next slide. So it is the onus of the investigators to demonstrate the PCI is not unacceptably worse than the standard therapy for its benefit. They chose to look at a primary endpoint of all-cause mortality in a composite with myocardial infarction or stroke at 3 years. So can you go to the next slide, please? So these are the creation of a Kaplan-Meier curves on the left side of the screen. This is the use of it all meta-analysis, and you can see the darker line is medical therapy. The lighter line is CABG. The y-axis is death. The x-axis is time from randomization. And in this meta-analysis of 7 trials with individual patient data, at 3 years they did not find a statistically significant benefit for death. This appeared at 5 years with a p-value of 0.004 for patients with left main stenosis. If you look, and I've just put this out of interest, the Excel trial, and again, you can see the rates are lower. CABG and PCI have both improved greatly over the years, but you can see a very similar shape of that early divergence compared to medical therapy compared to PCI and comparing PCI and CABG. So, go to the next slide. So we know in terms of benefit for CABG in the scenario of left main coronary artery disease, there is actually minimal effect on MI and no effect on stroke. In fact, it doesn't make any biologic sense that doing CABG would improve stroke over medical therapy. So the addition of MI and stroke into a composite with mortality to show that it's preserving this benefit really doesn't make sense. It adds noise around the expected benefit of the standard CABG, and that is mortality. So by doing that, by adding in outcomes within a composite, it adds noise, and this favors a finding of non-inferiority. Furthermore, and we'll discuss this in upcoming slides, there's greater concern when you include peri-procedural MI, and we will discuss that this is poorly understood. It's tied to biomarker thresholds that have been chosen arbitrarily in the past, and it occurred at a very high frequency in this population. So again, this favors non-inferiority. This was further exacerbated by the fact that the trial, because of difficult recruitment, stopped its recruitment early and actually recruited less patients than they had originally intended. So it drops their power, and they concede that. But again, this tends to favor non-inferiority. So, I have a concern, and I'm a trialist. I've designed quite a few randomized trials, and I appreciate it's always difficult to design that perfect trial. But I do think that there was a flaw at the start of this, and I think there was an opportunity, given the sample size, to set up the non-inferior design appropriately, as described by Fleming et al. In 2011 in clinical trials, test against the standards proven benefit, and ensure that you test a non-inferiority margin that's reasonable. Next slide. Pablo.
So do we try to address the prior point before we move to the next one, David?
I think it would be good to stop there. Go back, Rich, maybe back one slide, and just talk on the non-inferiority aspect, because that is, as we were discussing before we started, maybe not this one so much as the next one. There you go. Around how do you design and interpret non-inferiority studies, and so Pablo, so you've heard Rich's point that really the study, if I'm hearing him correctly, in his mind the study should have been designed with a mortality primary endpoint, because that was the original use of meta-analysis was on mortality, and a non-inferiority design was fine, but it should have had, it should have been with adding in these other endpoints for the effectiveness side of things may not be may not be ideal. So what do you think about that? About why wouldn't why is this okay, or why would mortality have been impossible? Why do you think that, we're going to speculate as to why the Excel investigators did this?
So I think there is like a feasibility part of, right? So I mean, so let me go back. So the probability of dying in this trial was like 2% per year. That is pretty low, right? It's like almost, I mean, the mortality, the cardiovascular mortality up to 5 years represented almost like half of the deaths. When everybody walking on the street has a death mortality risk, I mean, the chance of dying from cardiovascular disease is a third. I mean, so, I mean, these people were not that high risk people. So if you design a trial just to answer the entire question of PCI versus CABG in a single trial about mortality outcome, then you will need like probably several thousand more randomized, and that of course impacts the feasibility of doing that such large trial. I have to agree that combined outcomes are a very often problem in clinical trials in cardiovascular disease. I mean, unnecessary or not unnecessary, but putting this combined outcomes sometimes brings some noise. I agree about stroke. Actually, several meta-analyses of randomized trials show that stroke is more frequent with CABG compared to PCI, I mean, in randomized trials. So, and all of them happen periprocedurally, and then the Kaplan-Meiers become parallel. The point is that you are looking for non-inferiority and you have an outcome is probably favorable. I'm not saying stroke is not important. Actually, for patients, sometimes it's more important than death. But I mean, putting stroke into the combined outcome, of course, brings noise to the trial interpretation. But I think they wanted to look, the investigators, I tried to guess what was in their minds, try to do something feasible with outcomes that are important to patients and similar importance. Death, stroke, and MI are similar importance. I mean, MI depends if it is a procedure or not. Of course, we are going to debate that later, but I think that's probably the key aspect. And
I agree, Pablo. I think it was a consideration of feasibility. I did do sample size calculations. If I was at the start of this trial and what I would have projected that the sample size would have required with time to event analysis, and it would have been closer between 3,500 and 4,000 patients based on the assumptions that I would have made. I guess the question is so if you have a trial and you say, okay, doing the right thing is not feasible, do you contaminate with other things? I think if you can't do it right, you may, but I think they could have done it right, because mortality does reach, again, there's definitely controversy because it's a secondary outcome. They weren't powered for it. There's issues around cardiovascular, non-cardiovascular that we can discuss. And, but I think they could have done it. And the second thing is, I do agree stroke and MI are important. If they had designed this as a superiority trial and said, we believe that stroke prevention is so important, and PCI is better than CABG of it, and we'll maintain mortality benefit, and MI will be similar, but we're going to save strokes, then they should have done a superiority trial. If the non-inferiority design should have forced them to do mortality as their outcome, and secondarily, they should have explored stroke and MI as explanatory variables.
So I'm going to take the prerogative of the moderator. I'm going to make a final comment, and then we'll move on so we can keep going. This is obviously a very important discussion, and I hear both sides. I mean, I think clearly it could have been designed as a mortality non-inferiority trial, but would they have ever gotten to the end of it? There are these feasibility issues, and it had an industry sponsor who doesn't have an infinite timeline. So there are many different factors. I also, as we discussed beforehand, have a particular view of non-inferiority designs, which is non-inferiority at some level is how you design a trial. It's how you power a trial. It's how you figure out what your sample size is. But when you get to the end of the day, you have the data. And and nobody likes non-inferiority because you always have to have a margin. And, let's say we picked, we did a mortality trial and we picked to make it work, probably you would have had to pick a 40% excess mortality or something like that to get there, which is a pretty big difference in mortality. And so it would have been unsatisfying to say, okay, it's not inferior, but it could be 35% worse, which is frankly what we observed here in this trial. So I think my own personal preference is, it was designed as a non-inferiority trial that can be absolutely criticized, But now we have a bunch of data that we have to interpret because we have a randomized trial with very rigorous data collection. We have a lot of information on 1,900 patients. This fits into in the story with other trials. So we should look at what information we have. But I accept your points, Rich, that it's again, there's a lot of arbitrariness and perhaps capriciousness to a non-inferiority design. And personally, I never find them particularly satisfying. They always leave you with a sour taste in your mouth, almost always, and this one does as well. So I think you're right to point that out. So let's move on, if that's okay, to the next point. If there's something which I left out or you can get a last word in, we'll come back at the end. So go ahead, Pablo. I think you're up next.
Yeah, sorry. I'm going to talk about a little bit about procedural MI. Actually, Rich is going to pop in the middle as well. So there are many unanswered questions of this. And a few weeks ago, this actually made this webinar happen, that the Excel investigators released the third universal definition of myocardial infarction and was contrasted with what we know about the protocol definition. So apparently, we can go back about the controversy about who has, or the timing of the how has been this released. But in general terms, the protocol definition is mostly a biomarker, but not biomarker only defined MI, was more frequent in Cabbage, while using the third universal definition that Rich is going to explain, which actually is different for PCI and Cabbage. There are different definitions or different thresholds, was higher in PCI arm. So let me just go quickly over this. I mean, when we think about MI, we need to think about from patient's perspective, right? So why people or patients want to avoid an MI? Because they know that it will live less time than they should be because of this MI. Then their quality of life, because if they develop heart failure, shortness of breath, they know that they have an MI. That is a psychological impact. The risk of a sudden death, right? I mean, in a new MI or subsequent consequences of the MI, I mean, as well as going back to hospital, which is usually unplanned, and a revascularization procedure. So procedural MI shares a lot of aspects of patient importance with spontaneous MI. Like it reduces life expectancy when it's the same size, and if that is the case, of course, as well reduces quality of life. Then in terms of risk of sudden death, well, with the procedural MI, at the hospital, of course, likely not, because you have defibrillators all over the place monitoring. But then when you go home, you are at risk of sudden death, right? Whether your MI was spontaneous or procedural. And then, of course, the likelihood of getting to hospital, you're already in the hospital when you get a procedural MI. But you are more likely to have a longer and more complicated admission, or more likely to be readmitted to the hospital if you have a procedural MI compared to not having it. And revascularization procedures are not very often done in patients with procedural MI, right? Most of these are managed medically. So I move to Rich to explain or go over the universal definition. Go ahead, Rich.
Yeah, so the points that I first want to start off with is you can see in the center of the screen there is two words that are surrounded by a box, and those words are arbitrarily chosen. So I just want everybody to be aware that in defining the threshold for biomarkers for myocardial infarction or myocardial injury, what was done was the distribution of CKMB or troponin for the general population was taken, and they said, okay, the 99th percentile and beyond is abnormal. We're going to define it as abnormal, and we are going to use that as the basis of choosing what the threshold should be for MI. So in this case, the myocardial infarction for type 4A at the top for PCI was again arbitrarily defined, not associated with clinical outcomes, but arbitrarily defined as an elevation of biomarkers greater than 5 times the upper limit of normal in a patient with normal baseline values or some percentage rises thereof. So in addition, they have to have symptoms, they have to have the ischemic changes on the ECG. Similarly, in this universal definition, again for Cabbage, it's an arbitrarily defined elevation of the biomarker to 10 times with a normal baseline, but they also have to have ECG changes. It's hard to present clinically after CABG because you're usually intubated, you're receiving morphine, dilaudid, etc., and you really can't express that you're having pain. So it's a biomarker plus ECG for CABG. But it's very important to highlight that these thresholds were arbitrarily chosen. So next slide, please. So the first trial that my team designed was the SIRS trial. That was steroids in cardiac surgery. It's in a box there. We published that in 2015. And we came to realize, because we had included peri-procedural MI in our primary outcome, and we came to realize that this area was a mess in terms of defining this. So we had thought that steroids, it reduces the inflammatory effect of the CPB machine. It therefore reduces the deleterious effects of all these bad interleukins in terms of ischemia reperfusion, in terms of stroke and penumbra, in terms of all sorts of things. We thought it was going to be the holy grail. Unfortunately, it wasn't. The trial was negative. It did have some interesting information for us, but we realized it was a mess. So we decided, after 7,000 patients were recruited, and the sample size was 7,511, that we would define myocardial injury, procedural myocardial injury, based on events. So we used this complicated method of Majumdar, a statistical approach in which we said, we're going to establish what is the lowest threshold that is associated with a twofold increase in the risk of death, and that is still significant when adjusted for known predictors of mortality. And in that case, we used the Euro score. So, and for the CABG population, we came up with a CKMB mass greater than 6 times upper limb normal and activity greater than 40. And you'll see we had to divide, it's so complicated, we had to divide activity and mass assays with different thresholds, which I don't even think had been done prior to this trial. Secondarily, this was only the CABG. We actually had to also define MI for non-CABG surgery, because the release of the CKMB was different by you cutting the myocardium, cutting the aorta, cutting the atrium. So you get a profound release, a lot of noise in CABG surgery. Next slide. And you can see, so these are various definitions. So subsequent to this, I had this brilliant PhD student, Emily Bellicote, who's now a rising academic star in perioperative medicine. And she looked at the coronary and off-pump, on-pump trial and looked at all these different definitions, universal definition from 2007, 2012, 2013, coronary definition MI, SIRS definition MI. They all had different frequencies, and they all had different hazard ratios for mortality. What this tells me is, unfortunately, this field of defining perioperative MI is currently a mess. We just don't know how to do it. I would argue that, again, this highlights, given that this was a major driver in the results of Excel, and in fact, you see the fragility, because if you change the definition from universal to their protocol definition, it totally changes the results. It just should never have entered into the equation. Pablo.
So that's, so this is, well, you still have a few more, I'm sorry.
Oh yeah, so next slide. So this was the definition of the procedural MI that was used in the Excel trial. So their first part was similar to the universal definition, and they used a cutoff of CKMB for both of them, CABG and PCI, of 10 times the upper limb of normal, but they did not require the ECG changes, particularly in the CABG population. And I will tell you right now, because of SIRS, we went on to perform a study called Vision Cardiac. That study is now, we've just received the reviews back from New England Journal of Medicine. Hopefully it will be published there. We recruited 15,000 patients in that study, prospectively followed these patients, collected many biomarkers on them. And I'll tell you right now, this stuff isn't even in the ballpark of the correct definition.
You can't tell us the correct definition because it hasn't been published yet. Okay.
You got it.
How about this?
So basically,
Pablo,
that was my turn.
So this is, I think it's, let me just interject before we let Pablo go. There's one thing that I think we can all agree on, for sure, which is that periprocedural myocardial infarction is a mess. I don't think there is any. I mean, I've been working in this area for PCI for. I mean, we first published the first study I can remember publishing on this was in 1995 on this question of what is the threshold for an appropriate and we weren't even trying to deal with bypass surgery. So it's 25 years later. I probably published another 10 papers on it, and it's still a mess. So I would absolutely agree with that statement. Pablo, can you sort out the mess?
Of course not, but I probably put some further guidance for future investigations. So in terms of prognosis, I mean, although this data was not available before the trial, because actually it's kind of a internal validation of the definition, you can see that the risk of death is 2- or 3-fold, and also cardiovascular death. If you have a periprocedural MI, based on that definition, whether you got PCI or CABG or in a similar magnitude. So this is kind of not only, so this biomarker mainly based definition is not that different, I mean, in terms of outcomes to what maybe you have seen they are reaching in the coronary trial validation of the SEERS definition that was a biomarker only. So the point is that it's not necessary to really support everything to have a prognosis impact. So maybe sometimes with biomarker mainly definitions, you can reach some prognostic validation. So, and this is probably the key, the question is here. I mean, we have in a decade, 3 universal definitions, and now we have a 4th one, and it's called universal. And that actually, instead of bringing us like being sure that it's something good, I mean, putting something, the wording universal, and 3 in 10 years, that actually, I'm more skeptic that is something that is robust in terms of why we don't have 3 universal definitions for stroke or many other things we measure in clinical practice, because that actually is the problem. So we have here the first universal definition, which one cell goes down and you have an MI, and in the same bag, you will have these large myocardial infarctions of 10 times CKMB, equivalent to 70 times troponin. So when you put everything like this, so if I had to explain my father, who used to race cars in Formula 2, so if I had to tell him the risk of mortality with a traffic accident, and I define this in a very sensible way, every vehicle moving more than 10 kilometers per hour is in this data set, defined as at risk of a traffic accident death. You will see this, right? I mean, point estimate closer to the null and large confidence intervals. But if you get more, you put a higher threshold, okay, CKMB times 10 or more, or just put the cars that you know that are more likely to have a death, then you will see the effect and the reasonably narrow confidence interval. So what happened in the past, that's why the universal definition has that bad reputation, is that many studies shown that the universal definition, especially the earlier ones, didn't have prognostic impact, actually. So, and the debate of if a procedural MI is prognostically important or not, it's not a yes or no. Of course, a procedural MI will be bad for the patient. The question is, how large and how we measure it. That actually are the unanswered questions. So, and then an aspect I hear all the time in terms of validity. So people saying, okay, the definition they use in Excel is not validated. Okay, it's not a matter of opinion. I mean, there is a lot of science behind measurement validity of, how valid is your measurement. I mean, in terms of phase validity, is one of the domains. It's pretty clear that if a person or patient in my ER with atypical chest pain and troponin times 1, I mean, the upper limit has an MI, why not times 70? I mean, of course, that has phase validity. We are talking about an MI with that such increase in enzymes. Then for construct validity, that really, in terms, let's say, with the correlation part of the construct, then that peak of CKMB times 10 or more correlates with other adverse events related to MI. I mean, poor LV function, heart failure, readmissions, Q waves on the ECG. So there is a correlation from the construct validity point of view. Then about the prognostic and predictive validity, then you got it. The SEERS definition validating on coronary a subset of CABG patients, and the Excel trial itself. And about criterion, there are studies showing that mainly CKMB and those thresholds are associated with a large amounts of late gadolinium enhancement in the MRI. So that's criterion validity has to do with comparing with the gold standard. So the Excel definition, although controversial as any other periprocedural MI definition, fits many of the validity domains that we may discuss when we get deep into this discussion. And another aspect that is key is this is context specific. I mean, there is nothing wrong with, I mean, not perfect, but nothing really wrong using the universal definition for stent A versus stent B. I mean, same PCI, differently done or whatever, but PCI people. Then graft A, let's say Lima versus a venous graft, because we're talking about with the two arms are receiving CABG. But if you do PCI versus CABG trials, then you get into trouble, because as Rich mentioned, the definitions for MI have very different thresholds. So there is a high risk of ascertaining bias. So there are many prognostically important MIs happening in the surgery group that will never be diagnosed using the universal definition, and many less important MIs on the PCI will be likely detected. So that kind of biases, put some dust in the way. So I'm done with the
okay. Well, so we've heard many different points, and again, I think the one thing we can all that everybody said is there is no singular definition of a paraprocedural MI that is correct. I think that's that's clear. I do like the point you've made here, Pablo, about the MI definition needing to be context specific, because I think that's a very critical thing to keep in mind is what is it that you're actually comparing, and at least in my mind, and I'd like to hear Rich's thoughts on this. If you're doing, if you think procedure-related MIs are relevant in any way, wouldn't it make them, doesn't the endpoint, shouldn't it have similar prognostic relevance with respect to whatever other prognostic endpoint in the two treatments? Shouldn't the MIs be equally prognostic? Isn't that probably the right way to choose? Whatever arbitrary threshold you choose, you want it, and it doesn't have to be the same. It could turn out that it's, the threshold is different for similar prognosis with one treatment than the other. Isn't that a pretty decent way to resolve this?
Yeah, well, I mean, somewhat. I think it's more complex than that, because what it comes down to is you have to have some knowledge of the actual distribution of concentrations of CKMB after each procedure, because what could be happening here, because they have demonstrated that the threshold that they set for CABG predicted bad outcome, and the threshold that they set for PCI predicted bad outcome. But what may be happening is for the CABG outcome, it's actually being driven by values that are much higher. That's why, again, in SIRS, we use this method that Majumdar came up with to sequentially lower the threshold testing to find that lowest value independently associated with mortality. And that wasn't done here. So it may be that when you have a CKMB 70 times the upper limit of CABG, you have this horrendous blip of mortality, and that drives all of that association when you choose your cut point of 10 times. And the converse is that for PCI, it may be that they never get to 70 times or 100 times unless you've just totally trashed the vascular system. But sorry, did I lose you guys there? No, there you are.
No, we're here.
The distribution clusters much closer to the 10 times value or the 5 times value. So you have to have a much better understanding of the distribution of this data set. You can't just choose a cut point and say associated.
No, I mean, that is fair. I mean, you obviously need larger sample sizes than is available in this single trial.
And that's why we undertook Vision Cardiac.
Right. So and similar work has been done. Again, I ran a trial, a decade ago called Event, where we collected biomarkers in 10,000 patients undergoing PCI and did the same sort of it. We didn't probably have the same fancy statistics, but we tried to look for what, the thresholds that were important. And that's where, I can't remember if we came up with 50 or 70-fold on troponin as to where where things really seem to inflect. But I do think, we're not going to resolve this here today. We'll need to see your paper that's published in the New England Journal. Hopefully it will get in there, because you're not supposed to tell people that it's going to get published in the New England Journal. They take them away.
Well, hopefully not.
Okay, but
it's under consideration.
Okay, good. There you go. Actually, you're supposed to say a journal in the northeastern of the United States or something like that for it. We're not going to resolve it, here. But I think if I could offer one other thing I would say that the one definition that is clearly not useful is the universal definition. I don't think there's any. Again, as you pointed out, the word arbitrary appears in it enough times to make you realize what it actually is. And trying to use that in the context of a PCI versus cabbage trial is silly. Maybe we shouldn't be looking at procedure-related MIs at all. Maybe we shouldn't be looking at MIs at all because, again, we diagnose MI. Patients come into the hospital with chest pain and they have one myocyte that died. It's an MI these days with the high sensitivity troponins. So it is. It really is a moving target and. One that's we won't entirely resolve, but I think I think it is important to recognize the different things that go into the definitions, how one would choose it, and I do think that if we knew what sort of sizes of MIs were prognostically comparable with a full distribution, that would make sense to me as the way to choose it. It's just that we don't really know it with the comparable data sets right now. Is that a fair statement, Rich? Would you accept that?
Yeah, I agree. I agree.
Great. So what's next, Pablo? We're kind of getting low on time, but we still have about another 20 minutes.
So
non-inferiority versus superiority. I can handle this in 5 seconds. So hit return here. Is there no? There we go. So there has been some controversy in discussing Excel regarding the 5-year analysis and why wasn't it analyzed using non-inferiority. This is the actual analytic plan. So the only pre-specified analyses with respect to preserving power and that had non-inferiority in them were these 3-year analyses, which was the time point for the primary endpoint assessment. They were, the primary endpoint was death, stroke, or MI, with at the 3-year time point with a non-inferiority hypothesis and a prospectively chosen delta. And then the way that they preserved their statistics was to do one of what we call a hierarchical or ranked sequential analysis, where each analysis is conducted sequentially until you find one where the p-value is not less than 0.05, and at that point you stop. And so again, these are the endpoints. I don't want to really belabor this because I really would rather go on to the point that I made earlier, which I think is something. Non-inferiority trials are very common these days. They're very complicated. They're much more complicated to understand than superiority trials because they involve this non-inferiority margin. And what I will say is when you've done them and when you've designed them, the non-inferiority margin, there are some statistical ways to come up with them that are used in drug studies for the FDA and those sort of things. But in clinical studies like this, where we're comparing 2 strategies that have very different profiles in some way, there is no very satisfactory way to come up with a non-inferiority margin because nobody, if you really ask, if you ask clinicians, they don't want any non-inferiority at all. We would like PCI to be just as good, if not better, than bypass surgery. That would be ideal. And bypass surgeons and cardiac surgeons would say, well, sure, we would like that too. We'd like to have evidence of that. But once you accept that there is some, you're going to have to do some trade-off, everything gets muddy. And so again, my own view of it is non-inferiority. It's a way of deciding how large of a trial you're going to do. It does have some relevance for interpreting the primary endpoint at the primary time point. But everything after that, in my own mind, is we should describe them, not even with p-values. We should describe them with confidence intervals. We should look at the confidence intervals, and we should decide for ourselves as a patient or as a clinician whether those confidence intervals are so wide that you can drive a bus through them, and so we should not, if it's not at all non-inferior, what trade-offs are involved. I just think once you get past the primary endpoint here, everything is descriptive, everything should be really considered the totality of evidence, and everything is about trying to understand whatever trade-offs there are. Let me again open that up to Rich and then to Pablo for your own comments as to how do you think we should be interpreting the 5-year endpoints? Do you think we should have had a non-inferiority endpoint there? Again, Rich, you already said you wish it was a 4,000 patient mortality trial with
Yeah. Well, in hindsight, again, looking at the data, perhaps again with, I mean, if you believe the all-cause mortality, that they would have had the answer of terms of non-inferiority at 5 years with the samples that they had. But you know, unfortunately, that's just not what they did. So you can't say that with confidence, right? So that's it. So and that was set in 2017. Myself and my PhD student wrote a letter to that effect, predicting this exact scenario. So saying that their primary endpoint was noisy. There was some issues that we had with the Delta, but that was the consensus from the leadership. They didn't involve surgeons, but we felt again that they were measuring at the wrong time point and the wrong outcome. Period. And now you're
those things. So do you feel that, you know, I mean, given all of those concerns, that we should, I mean, how should we use the information we have? Because again, that's what I'm trying to understand now. Now we have a trial, we have 5 years of data, we have certain information. How should we use that information?
So let's David, I suggest we move on, because I think we can have that discussion as we close, because you know, fitting trials to patients isn't perfect, right? We all know that. And you know, Pablo's going to make the point here around guidelines.
So Pablo, you take it over and talk about how are we going to get past this?
So actually, I think the answer is here, right? I mean, to put some responsibility down from the investigators. So they role in the current understanding of, let's say, summarizing the evidence for clinical recommendations for practitioners. Then their role is mostly not to solve the hypothesis, rather to run the trial in the best way possible, the most valid way, and report it properly. And then, of course, interpretation is out of question. That is not a big deal. So in terms of non-inferiority versus superiority is not relevant for clinical practice guidelines. So we do for a guideline, we go for each separate outcome. So we don't care how many composite outcomes were in the primary, secondary, or whatever. We deal with in the problem of multiple testing. That is actually the problem of doing secondary and tertiary analysis. We deal that with meta-analysis, right? So we have several trials. So if there is a random error in one trial, you will balance with the others. That's actually the role of that. So, and then if you see in this process, the very summarized process of a great development guideline, which is probably the state-of-the-art process for developing clinical guidelines in a reproducible, honest way, then you don't see that the hypothesis type of testing they are doing, it that doesn't really care. I mean, we struck the guide. So whether they select the non-inferiority or superiority for practitioners is not important. Maybe very important for a single trial interpretation, but that's not the way we practice evidence-based medicine nowadays. We pull all the evidence together, we analyze it, we summarize it, put through a filter, and then guideline panels, people, values, preferences, everything is on the table. Okay, so that's probably my point.
So Rich, what do you think? Pablo says something similar to what I do, which is, we got a bunch of information, we've got to make decisions, and we can't always be purists. So what do you say to that?
Yeah, I think again, you need to use the totality of the data, and unfortunately, not everybody is able to read a clinical trial and appreciate all the nuances, because not everybody has all the training. So we do rely on guideline bodies for that. All right, and it's interesting because sometimes I get people quoting guideline evidence, guidelines recommendations as evidence. Well, that's not the evidence. The evidence feeds into it. So it's up to the guideline panels to be unbiased and go through a rigorous, transparent process such as that of grade to come up with the recommendations and based on the level of evidence they have. And I think the guideline panels are very, very important because of that for clinicians.
So again, so it's more of a synthetic process of trying to put all the information together in a in a relatively rigorous but importantly unbiased framework is the is the key. So,
and then it comes down to, I see a lot of calls. I mean, there's a lot of hate and a lot of love towards this trial. Retract it. Don't retract it. There's lots of trials out there with various flaws, right? And I assure you, these aren't evil people that did that. I mean, there may be some biases amongst some individuals. I have biases, of course. We all have biases. But, you know, I appreciate it. This was hard work to do this trial, period. Like, not many people can do this, right? So retract it, you know, have it out there. And it's these panels and ourselves that read the evidence and take away the points based on what they've presented. So it needs to be presented transparently. And I think that that's now coming out with pushing, but, you know, but that's it. So let's see what future iterations of guidelines say.
Yeah, no, I mean, I think that's a very fair, you know, way to put it. Again, I would, you know, I would agree that, you know, retraction doesn't seem to be relevant at this point. It's, you know, I mean, the only things that I think that we're left arguing about, again, there's, you know, there are issues around why it took so long to release the MI data of the universal definition. That's, you know, that's unfortunate.
Yes,
now that data has been, you know, been released, we have, you know, mortality data, we have stroke, we have, you know, all the endpoints that people care about at this, you know, at this stage. And we're arguing, you know, and the argument is just about the discussion section, right? It's how do you interpret this? How do you put it in context with everything else? And so retracting doesn't seem to be relevant. There's a lot of good information here. We should use it, not throw it away, because if you retract it, then the only information you have is the other three trials, which, you know, some people like worse.
Well, exactly. So why don't we move to that, Pablo?
Okay.
So here now, going to the body of the evidence, actually the way to the guideline process should follow. So this is what we expect when we think about a patient with left main disease. You put a stent, IBUs go home. But one thing is what you expect, one thing is what you get. We know that from McDonald's. So, and this is what happens in clinical practice, right? So we have left main disease, oh, you know, a 35, give me a 40, 16, and then you see, oh, but this left disease in the LAD and the diagonal and the RCA. Focal disease, but in a very nasty place. Then you see that you may resolve this with one stent. So, I mean, these people don't come like we expect. Even Excel trial, which did a very hard work in selecting the patients, a quarter had disease with high syntax score compatible with long-term benefit in terms of mortality and MI for CABG. So even Excel was contaminated with this. So what happens? So we use meta-analysis to inform clinical guidelines, but meta-analysis cannot work if we have many subgroup effects within the trials and between trials. So individual patient data meta-analysis is a methodological tool to deal with that. And this is the largest individual patient data meta-analysis from more than 10 randomized clinical trials comparing PCI with CABG, was published 2 years ago, and includes Excel up to 3 years. That already included a lot of, I won't say the word noise, but a lot of signal of this mortality increase. Actually, from 3 to 5 years, I did the math, is only 12 deaths. So talking about 2 extra deaths in favor of CABG. It's not a large number to think that it will drastically change, but still, you know, this is not the latest updated individual patient data because the 3 to 5 years are missing. But what has been shown there is that left main disease has almost identical 5-year mortality, while the main difference is inferior vessel disease. As your coronary disease gets more complex, more benefit of CABG over PCI. And you know, diabetes correlates very well with 3-vessel disease and progression of disease. And this is probably the strongest effect modifier in PCI versus CABG trials and the most infamous. So, but you can see that people without diabetes, 2/3 of the patients, I mean, 70% of people we see in clinic with coronary disease do not have diabetes. They have similar 5-year mortality between CABG and PCI. So now I will leave this to Rich.
Yeah. So again, this is an update study level meta-analysis, and on the top it's all-cause mortality, and the bottom cardiovascular mortality, and again including all the studies that included left main patients. So Excel, Noble, pre-combat, syntax. Again, you're getting a crossing of 1 on these forest plots, again suggesting that there's no difference. You know, Pablo, just go back to the first Kaplan-Meier curve. I mean, the one thing to point out is, again, this meta-analysis, this is a subgroup analysis. And the one thing that surprised me in Stuart Head's paper is that they reported the P for interaction. And as a methodologic purist, the way of looking at subgroups and to saying whether they're different or not is you have to look at the P for interaction. And the P for interaction was never presented for the left main, which is odd because they presented it for everything else. I looked at the confidence intervals. There's no question it would not have reached significance. So in reality, you can't confidently say that there's no difference here. You can't say anything. So with this data, because you've cut the data too thinly. You know, if their P for interaction was, you know, was highly significant, like it was for diabetes, I'd be confident in this. But right now, I think for mortality, I mean, once the Excel data is, the 5-year data is combined with this, it improves it. But right now for mortality, the best data that we have is actually the Excel trial.
Yeah, I agree. You know, I agree that not having the interaction p-value reduces your confidence that it's a true effect modifier. I agree with that. However, that's a fact. I mean, the people who had left main disease had a similar 5-year mortality. I agree that having a statistically significant interaction p-value will make you more confident of this. There's no doubt, but that doesn't take out the truth that the outcomes at 5 years look very similar. And that's why maybe the study level analysis support that. I mean, this is not a subgroup analysis. This is okay, subgroup of some trials, others were studying.
Yeah, exactly. And that's the complexity, right? I mean, you know, if you go out and you tease apart each one, the loss and follow-up and syntax, whatnot, I mean, the fact that actually the average follow-up of these trials is only 3.4 years or 3.2 years, again, not where we start seeing benefit of cabbage. You know, there's a lot of things that you can do to tear it apart, but I mean, in reality, I think, you know, as we move forward, you know, we are starting to gain an appreciation that we have 2 excellent techniques in the armamentarium of treating individual patients, right? So, as you showed, the Big Mac always doesn't look so big and juicy, right? So the patients are much more complex. They're much more similar to the one that's a bit sagging and, you know, they've got 80 years under their belt. And they may have a partner that's who's got end-stage cancer and they need to get home too. And I'm not going to touch them for cabbage if and disrupt the last 4 months with their partner. There's a lot of complex decisions that we make as physicians. We just have to have all this information in our background to be confident that whichever path we're going to take, we're going to produce an excellent outcome for that patient.
So we're really almost out of time. Pablo, remind me what other topics we still have to cover, if any, because I think we should actually start to wrap up.
I was going to tell this about adjudication, that I don't believe this is a big issue in Excel. I mean, after being involved in some trials and adjudication, I mean, tell that if to be non-cardiovascular, you really need a non-cardiovascular cause really obvious. I mean, a truck go over someone, something like that.
but having said it, because my issue wasn't the adjudication. The thing is it's biologically plausible, because they state at somewhere that the investigators state that it's not biologically plausible that that there's a mechanism where left main can impact the outcomes of cancer deaths or in sepsis deaths. Or I would pose that if you have a restenosis in your left main or your graph's down and you are hit by a truck or you have cancer or you get urosepsis, you have a higher chance of dying, period.
That may well be. I mean, I think we can, I mean, you're right that there could be reasons why a different revascularization could influence non-cardiovascular mortality in subtle ways, I think, for that. And certainly all-cause mortality still is the gold standard. To me, I look at the totality and say there isn't a difference in all-cause mortality either when I look at the meta-analysis. There is in Excel in one specific trial, but there's 3 others that have equal number of patients as Excel does. So it is the challenge with meta-analysis. The challenge, it's a retrospective technique. There are somewhat arbitrary decisions about, in some ways about how you combine and, do things. That's in many ways is the art of meta-analysis, and, whether separating out left main is, appropriate or not, is an interesting question. And, from my perspective as an interventionalist, we absolutely look at left main disease as different than 3-vessel disease. As a cardiac surgeon, I can imagine that you look at, it's all multi-vessel coronary disease and I need to get to work. On this. So there are reasons why both ways. What's next, Pablo? Quality of life. I want to just kind of, I actually want to kind of finish up for a second. You know, we can talk about quality of life for 5 seconds here because I did the work, so I might as well show it. So this is, you skip through that, skip through this one, go to the next one. So, you know, again, one other way to, you know, to look at the, at the patients in these trials is obviously, you know, when we do revascularization of any type, we're trying to do two things. We're trying to improve prognosis, whether that's, you know, saving lives or preventing non-fatal events, and we're trying to make our patients feel better. And so it is important to know if we are accomplishing similar degrees of anti-anginal relief here. And this is data that my colleague Suzanne Barron presented a couple of years ago and published in JACC, looking at the quality of life data from the Excel trial. We saw here, again, just categorizing patients according to the angina frequency. You know, at baseline, there were, you know, quite a number of patients who had daily or weekly angina. At 1 month, the difference favored PCI, but very, you know, very modestly, and no differences at 12 and 36 months with respect to angina relief, you know, comparable with PCI or CABG. And there was no quality of life data collected beyond 36 months, so we can't say anything about 5 years in this particular trial. Next, you know, what did differ was breathlessness. Again, looking at the Rose dyspnea scale, not surprisingly, at 1 month, you know, a big difference in favor of PCI. The bypass surgery patients are still in the recovery phase. Again, no differences at 12 or 36 months. And finally, I think looking at physical function, actually, go next. Yeah, so physical function is where obviously the biggest difference is. This is the physical summary scale from the SF36 or the SF12, where we do see, you know, the PCI patients get better, the CABG patients get worse at a month, and then they all come back together. And everybody lives happily ever after then. So the last slide on quality of life is, you know, what I think is, you know, just trying to put this in context. We've done this same analysis in 3 major trials of coronary revascularization. We did it in the Syntax trial of 3-vessel or left main disease. We did it in the Freedom trial, and we did it in Excel. And every previous time we did it, we found actually that bypass surgery was better. The differences were small, but they were there, especially at the 3 and the 5 year time point. This is the first trial we've done with adequate numbers of patients that didn't show any difference in long-term angina relief between PCI and bypass surgery. And probably it's because we excluded patients with the highest Syntax scores. Because if you look at the subgroup analyses in Syntax and Freedom, the more complex the coronary disease, the more extensive the coronary disease, the better CABG was at relieving angina. So, you know, another point in favor of CABG when you get to high Syntax scores. But we didn't see a difference here, so at least that's not a strike against PCI in the Excel trial. Any quick comments on this, Richard or Pablo?
No, not from my end.
Good. So is there anything more that we wanted to cover? I can't remember if there was more outcomes, but I think we're really at the end of the hour.
Yeah,
we've beat this thing up pretty good, I think, in terms of really dissecting a lot of the issues. If you're looking at the questions that have come in, other than the ones that are in Spanish that I don't understand, unfortunately, was there something you wanted to take on, Pablo? There was one in Spanish, because most of them in English relate to the MI definitions that we really talked extensively about.
We can start with the one that says, why include a poor surrogate periprocedural MI of a hard outcome, mortality spontaneous MI, if you're already measuring the hard outcome? Then
so that's a good question. So I think that's a very interesting question. Is, you know, if you were only measuring 1 year outcomes, then, you know, including this, you know, something to predict the long-term outcomes is relevant. But if you're measuring 5 year outcomes, does MI matter?
Yeah, no, particularly periprocedural, the answer is no. You know, it shouldn't have been there. It's just, unfortunately, it's a poorly defined surrogate. So, and that's what, you know, we beat it up, no matter what definition you use. It's just, I think, unfortunately.
But is the reason is it, you know, because we can't agree on the definition that we say it's bad, or is it because it's just bad?
Yeah, it's just, you know, again, there's all sorts of arguments. You get into, okay, you're creating a composite. You have components of the composite that just have that should have totally different weights, right? So if I come to you, David, and I say, oh, geez, your CKMB was 500 after your surgery, you know, and you survived 10 years, then, you know, you don't care.
You know,
Right? It's just
how
not,
you got there.
it's,
Pablo, do you agree
yeah,
with that? That the short-term outcomes,
right?
you know, I mean, especially periprocedural MI, shouldn't matter if you're monitoring, if you collect the long-term ones?
But Rich, you know, I agree that, you know, of course, if you have like, let's say 20-year follow-up, complete follow-up, and then you can dissect that. But I calculated the population attributable risk of periprocedural MI in CABG, and it's 13%. That means that if you can abolish periprocedural MI, you will save 13% of the incident deaths. That is not small for, you know, population attributable risk. You know, we usually talk about 20 like large. So I mean, it's important. I mean, we are causing the outcome we want to avoid at the same moment we are trying to fix it. I mean, fix the patient. I think should be measured. The answer is how, which is the best one. I don't have any.
But should it be in the primary, Pablo? Should it be in the primary? With
okay, that's probably a different question. I mean, because
that's
when if you talk about practice medicine, I mean, from the practitioner point of view, for the trial, I mean, I understand, but then when we dissect that, take that information for developing clinical guidelines and what we should do as practitioners, then you know how it works. You take death separately, MI, and then if you consider not periprocedural MI and put some weight, as you said. I agree that combined outcomes are, I'm not sure, maybe someone from MAC did it already, but I mean, how suitable if you put, apply quality measures or quality criteria to the combined outcomes published in several, cardiovascular disease studies, you will find that most of them have some inconsistency. I mean, it's almost impossible to find the perfect composite outcome.
Yeah. So I mean, I just read it just came across. It was published a little while ago. You know, Stuart Pocock put out this beautiful paper of win ratios. And a different way of looking at these trials, where you start with the most important things and you compare group A to group B on death, and then you basically you go down based on the importance of outcomes, and you create basically an overall ratio of that takes into account importance of events, whatnot. I mean, there are people looking at this, but as it exists, unfortunately, I think this was such a weak primary outcome for a non-inferiority trial.
No, I think
the trial itself has got great data within it, but it was just problematic from. I think
that's probably. I can't speak for the investigators, but I suspect they share your concerns. I mean, I think it's hard to design a trial. I mean, within the constraints. That's the problem. Is that I think they did not think they could recruit 4,000 patients. And they didn't have the time to recruit 4,000 patients or the budget to recruit 4,000 patients. And they're saying, well, how can we get
but it's partly our fault as clinicians, right? Because we went into this with preconceived biases, and their struggles with the recruitment reflected that.
That's no question of that. We were all seeing exactly the same play out in the COVID space with respect to some of the therapeutics and other sorts of things where. Doing a trial well could provide so much more information in a timely fashion. Let me finish up with one, summary question for both of you, which really is, maybe the money shot here. And we'll start with Pablo and then finish with Rich, who gets the final word, like the surgeons always do. For that, which is, do you think in 2020? That for a patient who is a typical Excel type of patient, a patient with in their late 60s with left main disease, but not overly complex coronary anatomy, at least theoretically syntax score less than 32 type of patient, do you think there is a role for offering them PCI, or at least having that in the discussion, or do you think it should be really only the patient who refuses bypass surgery should be offered PCI? So Pablo, you first, then Rich.
So, I think will depend. Let's say a patient, because some patients are higher, surgical risk. We're also including Excel. I mean, the typical, you mean, let's say, low risk patients.
Low risk patient, yeah. Patient is healthy. But pretty like the patients mostly in this trial who had, 13% 5-year mortality. So
I will probably put that into the table. In the discussion. I would probably emphasize to have a clear view, and probably not available here yet, but I'm really pushing for the clinical decision aids, all this material they can use and watch. and has an option of course, after explaining the patient properly, both things and the data so far, more likely them to probably select for CABG if they're very low risk and very young, right? But I'm not sure after you reach a little about age, I mean, go a little higher about surgical risk, then the patients will probably be more skeptic. I mean, let's say the increase of death, we couldn't get into the details, but I also calculated, the fragility index. The Excel data on mortality is very weak. And as Rich said, like the stopping early the recruitment is a problem for non-inferiority. It's also a problem for random error of outcomes. I mean, if you stop early, you're more likely to find spurious associations. That should be also balanced for mortality as well, especially if the cardiovascular death was no different. So after looking at the meta-analysis, the totality of the data, if there is the signal for increased mortality with PCI over CABG in left main is about 10% relative. 10% relative of a 5-year outcome rate of 10%. I mean, it's a very few. If you put that in absolute numbers in phases to the patients, many actually will, some situations of their life will push for PCI. But again, I would say that, as I usually say, that when I select the patient for left main benefit in terms of PCI or CABG, I don't look too much at the left main, right? You look for diabetes, you look for the residual disease, you look for other social or economic aspects around the patient rather than just the left main as the main driving factor.
That's the easiest part to take care of. That's for us. So let's finish up with Rich. Bring us home with some good kumbaya here, Rich.
Yeah. So again, we've been talking about this. This is about distilling all of this evidence down to that patient in front of you, and patients just aren't as simple as a very straightforward Excel patient. Most commonly, they're distributed on either side. If I have a 65-year-old individual with a very stentable left main, that I think patient preference also needs to come into it. But the discussion does have to be transparent, right? The Excel data does suggest that at 5 years and beyond, that there's a higher chance of being alive with bypass surgery. But at the same time, I see my patients post-op. And I participate in a lot of transcatheter procedures, and I see them post-op. So I've got that views, and I appreciate that some individuals do not want to be knocked down for the length of time and endure what they have to endure when they go through a CABG. So as long as discussions are transparent. There's considerations of syntax score, morphology of the left main, social considerations. I'm there as a physician to support the patient in making a decision based on best evidence. And Excel does provide a lot of good evidence. Despite what I perceive as some flaws, and I'm sure there's lots of people who disagree with me, it provides lots of good evidence to guide patients. And I'm fortunate. I work in an institution and Pablo worked with me. What our relationship is like with our intervention cardiologists. We're best friends. We support each other. We've got a great TAVI program, great PCI program, great CABG, or all sorts of surgeries. It's important that we work together as a heart team. Period.
There you go. That's the kumbaya message. And I do think. I think that's a great message. I think there are roles for both. The Excel trial, warts and all, provides a lot of good information. It doubles the amount of patients we have in randomized trials of these techniques. And so it provides us with, more certainty. It also provides us with some, real areas of uncertainty around the periprocedural MI that we've really wrestled with here. But at the end of the day, I think, both treatments do have a role, but informing the patients in an unbalanced way is probably the way, the best way forward. I don't know what the guideline committees will decide, whether there will be a reevaluation. It's I have learned over the years that it's there's an advantage to being first, because when you're first, like bypass surgery was first to treating left main disease, the randomized trials of left main disease versus medical therapy were 100 patients. I mean, that use of meta-analysis was mostly registry. It wasn't even randomized trial because the left main patients with medical therapy had like a 60% 1-year mortality. It looked like severe aortic stenosis back then. And so it's, again, then you get established, and then it's really hard to displace the guy who's at the king of the hill. With it, it takes a lot of work. It takes and it takes an incredible technology to get there. And we're probably not, we're not equal. I mean, there's no question we're not equal. We're better on some things, we're worse on others. Patients ultimately will choose. Well, I want to thank both of you guys. It was a tremendous program. Pablo, mostly you for really putting it together and having the inspiration to do it. Rich for being such a willing participant and really I think representing your whole discipline, both your clinical trial discipline and your cardiac surgical discipline incredibly well. It's been a lot of fun for me to participate as well, and I hope people learn things. I'm sorry we didn't have more time for more questions, but I think we covered an awful lot of them, and perhaps if there's more interest, we'll come back again and do this on TAVR. I'm sure we could do the same exact.
I'm a TAVR surgeon, so.
I know. So, but there's still places where there are debates. We know that. For it. Pablo, anything else you want to say to finish up? You want to finish up in Spanish?
Just thank you. Thanks to the audience for staying all the time. We had almost 300 people at the peak, and now we have over 200 people. And this is going to be recorded so we can share with many others who couldn't join today. Thank you, Rich. Always a great mentor in the ICU West at that time, and doing a lot of shifts together, and then on the TAVR program. And thank you, David, as well, for participating. You're a great guy. So thank you. Thanks so much for participating, and thank you, SOLACI, and everyone. Okay.
Yeah, thank you so much for organizing. So, pleasure.
Okay. Have a good night, everyone.
Good night, everyone.